Hi, I'm Stella Ogbonna, first year intern in Novant Health, New Hanover Regional Medical Center here in Wilmington. And I'll be presenting a case on treating hypertension can be life-threatening. It was a case of series of events where a patient was initially started on hydrochlorothiazide for hypertension, and the patient developed gout in the right big toe, and he was started on Meloxicam and Allopurinol for the treatment of the gout, and then the patient then developed toxic epidermal necrolysin. Sadly, I couldn't use his pictures. He had amazing pictures, but he's an inmate in the prison, and I tried to get through, but I wasn't able to get through to him. So my learning objectives today would be early recognition of 10, as we all call it, and the speedy discontinuation of the offending agent. Being able to diagnose and recognize that we need a multidisciplinary team intervention in the treatment, and also testing HLA-B5801 in specific races prior to initiation of allopurinol. So in our case, we have a 41-year-old African-American male with a history of hypertension who presented with discriminative skin rash around his face, back, chest, his bilateral axillary region, his eyes, his mucosa, his oral mucosa, and also his urogenitals. Of course, going through, which has been progressing for over a week, asking him questions. Yeah, that's where we got all the information that he was prior started on hydrochlorothiazide 3 months prior, and he had the pain in his big toe, and he was started on allopurinol and meloxicam, which then developed into 10. So upon arrival, we did start him on maintenance fluid. We consulted dermatology. Dermatology did a punch biopsy, confirmed the diagnosis of 10 with superimposed acute inflammation. Then we consulted urology, who recommended Foley placement to prevent any urethral obstruction. We also consulted ophthalmology, who recommended erythromycin ointment. And in all of this, because our center isn't a burn center, so we're trying to get him transferred to a burn center. So I was getting the recommendations that they didn't have a bed available, so we're still trying to fix him at our center. But he was also started on broad spectrum antibiotics. Blood cultures were negative. He got cefepime and Vang for 11 days. He also got IVIG for 3 days. And then he did well after 2 weeks, and he was discharged. Allopurinol, meloxicam, and hydrochlorothiazide were discontinued and all added to his allergy medication. Going to the labs, his labs resolved obviously before he was discharged. Going to the discussion of 10, I think 10 is a rare and life-threatening condition, which, you know, we probably just read about, and, you know, coming across it is very life-threatening, and it's been seen to be associated with 30 to 50 mortality rate. So being able to differentiate 10 and from Steven Johnson's and every other epidermal detachment disease is just recognizing the involvement of several parts of the body, and 10 is usually greater than 30% of full thickness epidermal necrosis. And usually the most common cause still remains medications, with the big ones being antibiotics, anti-epileptics, NSAIDs, and allopurinol. The big thing I really want to talk about is the HLA-B5801 allele, which we've seen that has been associated with drug-induced hypersensitivity. Even though it's not been approved by the FDA to get tested in, you know, the people that have this high risk for it, but the American College of Rheumatology still encourage and recommend the testing of HLA-B5801 before initiation of allopurinol in some particular races, being the Han, Chinese, and African American. So in our case, it was very similar. I think if we were able to, you know, get that test, or even if we go all the way back to do a proper med rec and realize that HTZ was what probably induced the gout, because it causes hyperuricemia, would have been able to stop that medication and avoid the cascade of events that occurred. So just summary and conclusion of my presentation is, number one, really big is medication reconciliation, and to perform and identify the causative agent and stopping it, which is big, because the treatment of 10 really is supportive care. There, I wouldn't say this is what we did, is like bringing everyone together and, you know, just trying to fix everything that is ongoing at that time. And also being able to let the patient know about what happened, and them realizing that going forward, those are the medications that should be avoided. And lastly, it will be trying to encourage more testing of HLA-B 5801 in those races that have high risk of developing drug-induced hypersensitivity syndrome. Thank you.
All right, thank you so much, Stella. Is there any like biomarkers or other conditions that might predispose patients to TEN that you could use in place of the HLA-B testing?
So from what I looked at, I didn't find any, but that's why I think all the research that I was looking at when I was doing this was more like, you know, talking about HLA-B 5801, none really, you know, talked about any other thing that I noticed. But I myself have never gotten the test done since after I got my patient. That's when I'm like, okay, I have to start doing this every time. Yeah, because it was pretty scary. Yeah.